Patients who have the unfortunate event of recurring, we initiate a conversation about what do we do next. And fortunately, as I mentioned, we have lots of options. For the patients that fall into that platinum-sensitive category or chemosensitive category, our best treatment options, at least at this time, seem to be a platinum-based therapy. Right now, our consideration is that these should be platinum-based combinations. And there have been a series of trials in platinum-sensitive patients that have tried to find what is the best of these. And there have been a number of these trials that have been done. The first kind of in this line of investigation that we established was that a combination was better than a single agent platinum. In that specific example, carboplatin was compared to gemcitabine and carboplatin. And that showed that the gemcitabine carboplatin combination was better. So then we moved on to the addition of bevacizumab, and the trial called Oceans added bevacizumab to gemcitabine and carboplatin. And this was a really interesting trial because the progression-free survival in that trial in the placebo arm was the same as the experimental arm of the prior trial. They were overlapped identically. But interestingly, the overall survival of the patients who went on to Oceans in both cohorts was double what we saw in the first trial. So again, to my earlier comments about the prevalence of disease increasing, this was a clear example where patients were actually living longer at that point in time, which was only about 5 to 7 years, where the prevalence has started to increase. So then we did another trial called GOG-213, which was to look at the addition of bevacizumab to paclitaxel and carboplatin, and again, another doublet. That particular trial, which actually has a secondary objective for secondary surgery, is still yet to report. But we did report on the benefit of bevacizumab to paclitaxel and carboplatin versus paclitaxel carboplatin alone. This is the only trial that is actually powered to address overall survival, and it demonstrated that effect. So bevacizumab was improved in a supplemental indication to paclitaxel and carboplatin and gemcitabine carboplatin in December of last year. It was a big win. But it does raise a conceptual and a contextual issue about what do you do with a patient who also might be amenable to a PARP inhibitor. GOG-213 was a study that randomized patients at the point of diagnosis. So at that time, you have to raise the issue or discussion with the patient regarding the use of a maintenance PARP. Because in the trials that all evaluated maintenance PARP, they were not given with bevacizumab. They were all given as a platinum-based doublet, and if they got a response, then they were randomized to placebo versus treatment, a PARP inhibitor. So my discussion has to be at the time of diagnosis. I say, how do I pick who's going to go on to Bev, because that trial showed an overall survival advantage, or who's going to go on to PARP because those 3 trials showed a benefit in progression-free survival, and we have yet to see what the overall survival is. And it's a tough decision. So what I would say is that it's multifactorial, and the patient and the provider need to be intimately involved in this decision-making process, because there are subtleties that are not oftentimes realized just on paper. For instance, when you use a drug like paclitaxel, you get hair loss. That's a big issue for some patients. For others, it may not be a big issue. And they may look at that kind of carrot for overall survival as the be-all and end-all, knowing that they'll lose their hair and they have a risk for hypersensitivity reactions to the carboplatin, and they have issue for neuropathy. It's not easy. So those kind of features have to be made as part of the discussion. What I have been doing, and not everybody does this, but what I've been doing is that we have been looking at the patients that are now known to have BRCA mutation, because we germline test everybody with a new diagnosis of ovarian cancer as part of policy. And so we know who these patients are ahead of time. In those groups of patients, we happen to see the strongest benefit across all the trials. So NOVA, SOLA2, and Ariel 3 all showed that the patients that carried the germline or that had a germline and somatic mutation did the very, very best. And those patients may ultimately have an overall survival advantage as well. Those patients, I think, clearly fall into, at least strongly fall into that side of potentially giving them a PARP inhibitor. And so I have that discussion with them. For all the others, the wild-type patients, I will have this discussion and offer an intermediary ground. And that would be, can we test the tumor for homologous recombination deficiency and then determine whether or not they should go on one or the other arms. As I mentioned, homologous recombination deficiency was only individually assessed in the NOVA trial. And even then, there were some patients who had somatic BRCA mutation that were included in that. But in that group that had HRD and were not wild type and were not germline, they showed a strong effect for therapy. In the ARIEL3 patient population, the HRD subpopulation also seemed to show an effect in that subcohort. And again, these are secondary exploratory analyses, but it does seem to say that damaged machinery are a potential cohort of patients who will respond even in the maintenance setting. And most of that's probably because switch maintenance and treatment are probably the same thing. In other words, I think we're kidding ourselves in looking at a patient who's had a complete response following platinum-based therapy is actually disease-free. Many of those patients have just small volume that we can't detect by imaging, and so essentially what we're doing is we're continuing treatment. And we know from ARIEL3 that we're continuing active treatment because even the ones that had tumors that we can see, 40% of those patients actually responded. So treatment and switch maintenance, it's a kind of a nuance. But it does bring up an important other caveat I want to address. And that's, what do you do with a patient who actually has a complete response? So you've treated them with platinum-based therapy, they're happy, C125 is normal, CAT scans are negative, and now what? They know that their likelihood of coming back is extremely high. It's higher than it is in the frontline setting. Should we treat them with a PARP or not? Well, that's another category of patients where HRD may be of some value. So if we check and we find that they actually have HRD, then I think our thoughts are that the PARP inhibitors might work quite well in that group of patients, even in the patients who have a complete response. I think that until the data are actually sorted out clearly across all 3 trials in those patients, it will help us to better define it. But ultimately, I think when the overall survival data mature, and we can put that in context with the bevacizumab story I mentioned before and the toxicities that are different between the 2 modalities of treatment, that'll ultimately help us to define what will be the optimal way to treat these patients.